you have to be very much, as a patient, be proactive and bring up this issue. You almost have to tell the doctor, could this be menopause? And even then, there is no guarantee that the doctor will say, oh yeah, you could be right. You have a good point there. Most of the time, you have to push to get the right tests. You have to ask to be referred to a secondary clinician in a hospital, like a gynecologist. You may have to even go private.
Welcome to Fempower Health. Georgie here. In today's episode, I interviewed Dr. Mandy Leonhardt, who is one of the co-authors of a book called Premature Ovarian Insufficiency and Early Menopause. After seeing so many of the struggles with her own patients and realizing that there's so little information out there, she decided to put her expertise on paper. And like I like to do with many of the authors that I interview on this podcast, instead of going through all the content that is in her book, I decided to pull some nuggets out, and we agreed on some of the nuances that we should cover in the episode that you may not find in the book. And what I love about this conversation is Dr. Leonhardt is clearly incredibly passionate and knowledgeable. So take a listen. And if you're interested in learning more about menopause as well as infertility, check out my Spotify podcast playlist where I've organized other episodes by other experts. So let's listen to Dr. Leonhardt. Hello, Dr. Mandy Leonhardt. It's such a pleasure to have you today. We are here to talk about your awesome book, which I'm showing so that when I do the video version of this, people can see it, The Complete Guide to POI and Early Menopause. So why don't you first start out by giving us a bit of your background and what inspired you to write this book that clearly people are craving to learn more about?
So I'm a medical doctor, and I specialize or I had further training after medical school in general practice, which would be like a family doctor in the US and in North America. So I'm a GP here in the UK, and I then went on to do further training in female hormonal conditions, in particular menopause, but also PMS, so premenstrual mood disorders. And as a female doctor, you see more women anyway. So, and I found that there was a lack of knowledge that I had before I did the training, and I realized I need to do more to help women in my day-to-day practice. I need to know more about it, because in medical school, and also in our GP training, we do not really get exposed to menopause and hormonal conditions in great detail. So I did the training myself. I got certified as a certified menopause specialist with the British Menopause Society, and I work predominantly now in women's health. I've also done further training in nutrition, so I'm a certified nutritionist, but this is not my main expertise. It's more of an add-on knowledge gap it was a knowledge gap I needed to close, because it is an important part of some treatments that you can offer to women to resolve health issues.
Okay. Well, thank you. Thank you for that introduction and your dedication to this topic. What's happening actually here in the US is a lot of folks are starting to subspecialize. And so there's the Menopause Society, and a lot of folks are getting the certifications there. You can even go on the website to find menopause experts. So it sounds like it's a global issue. So why don't we dive right into POI and early menopause? And so for those who don't know, and I'm assuming you're reading the show notes or doing your research that led to this topic, but just in case you didn't know, POI is primary ovarian insufficiency. But there's kind of a difference between POI and early menopause. And so I thought it would be helpful for you to first start by defining the difference between the two. And then we can dive into each of the different aspects. And by the way, your book does an amazing job of walking through so many aspects of dealing with this situation. And so what I wanted to do is leverage this interview to kind of go through some of the things that were really unique and interesting in the book that I thought would require further discussion through this live conversation. But truly, anyone who is struggling with this, I just think they need to use your book, because there is so much in there and we can never cover it in a 50-minute episode. So again, let's go back to the definition and then we can take it from there.
Yeah, and you know, Georgie, you made a good point there, because that was the reason why we wrote the book, because we wanted to help more women beyond my co-author, Hannah Short, and myself, beyond our own personal clinical practice, because it is so complex and we don't know everything, but we wanted to put it all together. So going back to your question, menopause, first of all, is a natural event. It normally happens from the age 45 onwards. Average age in the UK is 51. That is the time when you have your last period. After 12 months over the age of 50, if you haven't had a period, you would be called postmenopausal. That is entirely natural. Some women seek help for this, other women have no symptoms and are quite happy. Other women will have symptoms and treat them. Now, premature, so POI is premature ovarian insufficiency. It used to be called primary ovarian insufficiency, so the terminology over time has changed a little bit. We call it now premature ovarian insufficiency, and then there's also early menopause, and the difference is age. So a woman who is menopausal between the ages of 40 and 45 would be called early menopause. That would be called early menopause. So if you've stopped your period, or you have very, very few and very infrequent periods between the age of 40 and 45, and there is no other reason for this like pregnancy, you would be in early menopause. Women under the age of 40, and this needs to go back to all the way towards teenagers, so any girl or woman between the age of 15 and 40 who has ovarian dysfunction, who has ovaries that do not work properly, would be called, she's in POI, she has POI. POI comes with slightly different, the symptoms are similar, but there is maybe some ovarian function, so that they can fluctuate, it's a little bit going forth and back sometimes, whereas menopause is a definite state. It isn't, usually there aren't any fluctuations anymore. It's a definite state, your periods have stopped, and that's it. Whereas POI can, depending on how other complex conditions you have, can fluctuate. So this is basically the difference. Age, but also the variability in hormonal production, that there are still remnants of some production of ovaries potentially in some girls and women with POI, whereas menopause is really, there's nothing, or that there's really this is a definite state of menopause.
Okay, thank you for clarifying that. Now, can you naturally reverse it? Because I'm just thinking about a couple of people that I've spoken with who have had it and are very frustrated, because it seems as though seen as, okay, you have it, okay, you have infertility, okay, good luck.
Mm-hmm.
And there's like this group of people who are like, no way, you can definitely reverse it. And you've even said you can go in and out. So I guess talk to us a little bit about what might cause it and how that might impact whether or not you can have an impact on reversing it, so to speak.
Yeah, so our ovaries are glands. We have two ovaries, one on each side. They're the shape of an almond, slightly bigger than an almond, and they are hormone glands. They make a variety of very important hormones: estrogen, testosterone, progesterone, and DHEA, and a number of other important hormones. But when we look at causes affecting the functioning of our ovaries, we can not, in the majority of those who are affected, we do not find a reason why they don't function. However, in the most common reasons are usually genetic, so that you might carry a gene that prevents the proper development of your ovaries, for example, fragile eggs or Turner syndrome. So some girls would notice this very early on, so they would not go through a normal puberty. They would not have ovarian function that leads on to sexual development, for example, breast growth or periods. So they would know by the age of 15, all their friends have had their periods, yet nothing has happened on their side. They look a bit flat. They, in terms of breast development, they think, am I just a late bloomer? And when they go and see a doctor, the doctor might do some investigations and find that the ovaries are underdeveloped or not functioning properly, and this leads on to treatment. Then there are the type of women who have had a normal puberty. They've had functioning ovaries from the start, and then something happens along the way during their lifetime, up till the age of 40. Now, there are other reasons that can cause your ovaries from not functioning properly. Autoimmune conditions are very common. There isn't always a causation, but there is a very strong correlation between autoimmune conditions and ovarian dysfunction. One of them might be adolescence disease, where you've got antibodies against your adrenal glands, thyroid antibodies, Hashimoto's. So we know that the correlation is about 40% of women with POI also have an autoimmune condition where you develop antibodies from your own immune system that attack some tissue in your body, your thyroid gland, your adrenal gland, your ovaries, your muscles. Now, we aren't always sure whether this leads on to ovarian POI, ovarian dysfunction. We don't quite know what's chicken or egg, or whether it's just a correlation, but we do know there's a very strong correlation, and you can make antibodies against ovarian tissue as well. So this is another reason then that we have metabolic conditions like type 1 diabetes. Again, that's an autoimmune condition, or type 2 diabetes. We don't really know why. Our ovaries are quite resilient organs, but they're also very fragile. Then we have conditions, or not conditions, but we have situations where a woman has certain treatments that damage her ovaries. So if you've had cancer elsewhere in your body and you had chemotherapy, these are very toxic substances. They're meant to kill the cancer cells, but they may also damage your ovaries along the way. You may have had radiotherapy to the pelvis to treat cancer. There are women who've had their ovaries surgically removed. So if you are in surgical menopause, you have no ovaries, both of your ovaries were removed, maybe together with your womb, depending on the reason. It may have been cancer, it may have been something else. So there is a variety of causes that are very, very individual that lead to women and individuals ending up without ovarian function, or with very reduced ovarian function. And that's the bottom line. But in the majority of those who have POI, we do not always identify a cause.
Got it. Okay. And why do you think that is? So you're saying 40% autoimmune conditions. What percent is it with something that happens in their adolescence?
So genetic conditions are probably, yes, they're probably a bit rarer. And they get often, if you live in a country with a good healthcare system, they get, so Turner syndrome is about 1 in 1,000 female girls born will have Turner syndrome. It's not, 1 in 2,500. So it's not uncommon, and you don't always know when you look at the baby. It takes time to pick up developmental delays maybe, and obviously you'll notice. So any teenage girl who's 15, by the time of the age of 15, who hasn't had a period, should go and see a doctor. And then she will have further investigations, and then usually in the younger cohort, in the younger age group, we'll find a more clear reason, because they have genetic tests on in women maybe in their mid to late 20s. We don't always know. You can investigate them, and all the tests come back as normal. Yes, you may identify an autoimmune condition that attacks other tissues in your body, but whether that was the actual reason why your ovaries stopped working, we don't know. So that is very frustrating sometimes. And the other point that you made that I want to go back to, is it reversible? Well, no, it isn't. It isn't always, so it isn't reversible as such. We do think there's a theory that in some individuals, ovaries age faster than the rest of your body. So the ovaries, the eggs, deteriorate and age and go way much faster than the rest of your body, and there's nothing you can do about it really. There are ways of preserving fertility if you've had it before. So if you have functioning ovaries and you're going to have cancer treatment, there are ways of preserving existing fertility, but if you've never had functioning ovaries, you cannot reverse it, you cannot bring them back. Once the follicles, the eggs are gone, they're gone. And this is basically, so we also have to say is that whilst POI and early menopause are not the same, having POI often leads to early
Right.
menopause. Not always, but whereas early menopause has no probability of conceiving, there is about a 5 to 10% chance in POI that some women may go on to conceive naturally. Although I don't want to put hopes up here because it is extremely rare that it happens naturally, but it can happen, whereas menopause is a definite state where it doesn't happen anymore. So of course fertility is only one aspect. The other aspect is the lack of hormones that you're missing out on when you haven't got functioning ovaries. So it's a very complex condition. It's a chronic condition that isn't reversible. It is treatable, it's manageable, but it isn't reversible because there is nothing to reverse back to. Once the tissue is no longer functioning, you cannot revive it, if that
Right.
makes sense. It's like having type 1 diabetes. Your pancreatic cells that are meant to make insulin, once they're no longer there, you cannot revive them.
And I appreciate you saying that this is more than just about fertility because, I came on this passion for women's health after my own fertility journey. And I actually find that a lot of women become extremely educated about their bodies
Mm-hmm.
once they start having fertility issues. But then as I dug more into this, what I realized is missing in so many conversations is the root causes for any condition because like with POI, someone might think right away, oh my goodness, my chances of having a child. But as you were alluding to, it's so much more than that because our bodies are meant to function in a certain way. And in our reproductive years, it's meant for us to be able to create babies should you choose to have one. And so if all these things aren't operating the way that they're meant to, then it creates other potential health issues and side effects, correct?
That is very much correct because the hormones that are made in our ovaries contribute to our overall well-being. We have estrogen receptors in every single cell of our body. They, for example, just touching on bone health, bone mineral density. Bone mineral density is consolidated up till the age of 25. Puberty, for example, is a very crucial time during development. That's when you strengthen your bones. That's when you accumulate your entire bone mineral density that you have for the rest of your life. So by the age of 25, what you've got then, you've got for life, and from then on, it actually goes downhill if you're not careful, if your lifestyle isn't good. And menopause then is the next step when bone density starts to decline. So if you lack estrogen during that crucial time of development, you will start off with brittle or weak bones. By the time you're 25, you will not even have the strength of your bones to go and live on. So this is just one example, but these hormones are also important for our emotional development, our energy levels, our skin and hair, our brain function, cognitive function, emotional resilience. Testosterone is important for libido, sexual development. So they play important roles in our bodies, and not having these hormones at the right time or not having them at all is makes you very vulnerable, puts your body at risk of having other health conditions. So just to give you an example, premature ovarian insufficiency or early menopause is associated with an increased risk of dementia, osteoporosis, heart disease, muscle wasting, frailty, and if untreated, early death. I don't want to scare anyone out there because I'm just mentioning this here, but that doesn't mean we can't treat it. That doesn't mean it will happen. It means that when we're aware of it, we can take action. So please don't panic, but be aware of some consequences that if we do nothing, in the worst case scenario, that's how important these hormones are, and that's what I want to get across.
No, absolutely. So, what do you think? I guess what I want to go back to is how you can go in and out of POI, and also how you were saying that 40% of those who have this have an autoimmune condition. So, am I hearing you right that just treating the autoimmune condition doesn't necessarily reverse this?
No, so you don't go in and out of POI, you have POI,
Okay.
but when we measure So you have POI, let's say you haven't had a period for 2 years, and let's say you're not being treated, you don't receive HRT, you don't receive treatment. It may be that you have the odd periods every couple of years, a little bit of bleeding here and there. So very occasionally, let's say you are very relaxed, or you have a good lifestyle, and your body is in a healthy state, your ovaries might at that time produce a little bit of estrogen. I've had women who, when I saw them, they had very, very low estrogen levels naturally. They couldn't have HRT. Then we worked on their lifestyle. We worked on managing stress and inflammation. And then when they came back, we measured the levels again. They may have been a little bit higher, and we were like, oh, where does the estrogen come from? Now, I'm not talking about levels that would be physiologically normal in any other woman who doesn't have POI. I'm talking about it slightly more. So POI is still serious. You cannot reverse. If you have POI, you don't go in and out of it. But what happens is when you treat these individuals and you think you found a dose of treatment, for example, HRT hormone, or in North America it's called menopause hormone therapy. So if you replace the hormone, still you no longer have. Sometimes you support the body's functioning, and ovaries, you give them a little break from trying to make a little bit, or maybe some ovarian function gets reactivated, and temporarily you might actually contribute to the overall estrogen in your body from your own ovaries. So your own ovaries make a little bit of estrogen temporarily, and then maybe you have bleeding that you don't want, and you think, oh, why do I have bleeding now? That was one of the things that I quite enjoyed, not having bleeding. But actually that's because you had fluctuating hormone levels, and that's why the treatment is not definite. It's sometimes you start something, it works for a while, and then things change again, and then it no longer works. You have to tweak and adjust the dose. So occasionally we see hormone fluctuations that probably come from your own ovaries unexpectedly. And that's when, going back to your question about the autoimmune conditions, yes, if you do treat autoimmune conditions, if you reduce inflammation, if you reduce stress, if you have better nutrition, if you sleep better, and overall you're in a better place health-wise, as you will treat the underlying cause, ovaries will, or I'm not saying will, have a higher chance of showing some functioning during that time. Whereas when you're stressed, you're not sleeping, you are over-exercising, you're not eating properly, that is when you put further stress on these little glands that are already very, very vulnerable. Does that make sense?
No, it does. And maybe I'm oversimplifying this. Your ovaries are almost just a lot more sensitive than to the average person of not taking care of yourself. And also like sensitive to these autoimmune conditions. They just react a lot more heavily, that if you're not doing all the right things, they're just a lot more impacted. I mean, I don't know if that's a fair, potentially oversimplified statement, but that's almost the summary that I'm hearing from you.
Completely. Let's assume an individual who hasn't got POI, has normally functioning ovaries, maybe a 20-year-old woman. Your periods are, in my view, a vital sign. So if this woman is not on birth control, or not using anything to stop her periods, like an IUD or any hormonal contraception, she should have periods every single month. A sign of vitality, of health, is having periods. This is your prime fertility time. I'm not talking about a 46-year-old woman where things can go a little bit out of kilter, but a 20-year-old woman, if she has a healthy body, should have periods. I have seen, and when you're referring to reversibility of ovarian function, I have seen women who have functional amenorrhea. This is a condition. So basically, when we go back to basics, the brain communicates with the ovaries. It tells the ovaries what to do to mature an egg each month, to pop the egg out, wait for pregnancy to happen. If it doesn't, you start again next month, and then you have a period if it doesn't happen. So you can put your body into a state of such extreme stress that the communication between the brain and the ovaries is so disrupted that it doesn't work anymore. So your ovaries stop listening, your ovaries stop functioning. This is what we simply this is very simplistic, but that's what we call functional amenorrhea. And there are certain things that for example, contribute to that. Stress, so exam stress, you're at university, you've got you're completely stressed out because you've got exams coming up. These girls can have very much period disruption. Then not sleeping, sleep deprivation, so going out or not eating properly, being underweight, so eating disorders, but also over-exercising. So typically your female-driven, ambitious athlete who has very little body fat because that's a desirable feature in her sport, let's say a gymnast or someone who needs to be on the thinner side of being successful in her ballerina. So then combined with erratic eating, combined with a highly stressful lifestyle, she can put her body into a temporary menopause. She can stop her periods just purely because of the stress she puts on her body through a combination of lifestyle factors. If this condition could mimic early POI or early menopause, but it isn't. It is reversible.
Got it.
If you address the underlying causes, that is fully reversible. Yeah. So if you identify this athlete who has energy deficient, dysfunctional eating, too stressed, not sleeping, over exercising, if you manage that, her periods should come back. There's no reason that they shouldn't, because there was anything wrong with her ovaries in the first place. But she got herself into a state where her body was telling her, you are in no state to have a baby now. You cannot carry a baby now. Look at how stressed she is. She's not sleeping, she's not eating, she's always on the go. How would she ever deal or cope with a baby? Let's not do this. This is one of the messages that I really want all the listeners to learn from this, is that see your periods as a vital sign. It's your body telling you that everything is okay. And if you've previously had periods and they stop for more than 4 months, then please see a healthcare professional, a doctor, or someone who you can talk to investigate this.
So let me ask you this then. If you're on birth control, can it mask POI?
Mm-hmm. Yeah.
Really?
Yeah, so it's one of the treatment options as well. It is not the preferred first-line treatment. That would be hormone replacement. But we have in the combined pill, which contains 2 hormones. It's a synthetic form of estrogen, usually ethionyl estradiol, which is not the same hormone that your ovaries would make. It's 10 times stronger in terms of efficacy. And then you have a progestin usually. So the contraceptive pill does nothing else, or birth control pill does nothing else than, again, switching off the communication between the brain and your ovaries in a synthetic way. So your brain thinks that you're pregnant, and you are replacing your own ovarian hormones with synthetic hormones, and thereby you stop ovulation, which is needed to conceive a child, to pop the egg out, the sperm comes along, and so on. So you stop ovulation by disrupting the communication between the brain and the ovaries. And yes, if you are left on the birth control pill for, let's say, 10 years, the bleeds you might get every month are synthetic artificial withdrawal bleeds. They are not bleeds based on ovulation or natural periods. They are artificially induced withdrawal bleeds. Nowadays, we actually leave women on the pill for much longer than 3 weeks at a time, so they don't always have a bleed each month either. So they will not know if they have POI if they don't have any other symptoms. So they may be on this tablet for 5-10 years, and when they come off, that's when they realize things aren't how they should be.
So, wow. so let me ask you this then, because how important is it that I know that I have POI earlier rather than later? Because if the birth control pill, as an example, has some of these hormones, I mean, it's not HRT, then, like, I guess maybe a more simplified way to ask my question is, I have POI. I don't know I have POI. I'm on birth control. and then I get off birth control and discover it. Like, how bad is that versus learning earlier? Because we've talked about how your body needs to operate a certain way through your reproductive years to give you a more optimal, healthier life as you're older. And so if we're now delaying the
Mhm.
diagnosis, how much could that impact somebody?
It basically, it isn't, it wouldn't be a disaster, but it would remove some of your options that you would have had with regards to looking at more effective treatment. So let's say you have been on the pill and you come off the pill and you realize your periods do not return within a year after coming off. And then you start having menopause symptoms, you start having hot flushes and night sweats, and you go and see your doctor and they said, oh yeah, we'll come back, and it doesn't, and you're feeling tired, teeth not functioning, and then they do a blood test and they show your estrogen's really low, and you have a say to it, so you then get the diagnosis. Now, it you can't change the past, you can only change the future. So this individual would then have to discuss with a specialist what the symptoms are to treat this appropriately. Had she known it earlier, she could have had this discussion earlier. Does that make sense? Let's say she had found out 5 years earlier, she could have talked about fertility, options. She could have talked about maybe switching to HRT instead, which is the first line treatment, which is better for the bones, better for the brain, better for the prevention of cardiovascular disease. However, having been on the pill would have been better than nothing.
Okay.
So let's say the worst case scenario is a girl who is a gymnast, who is underweight, or someone who hasn't had a period and actually quite enjoys that. So it's not glamorous to have it. It's not great. We don't enjoy it. Some people actually have the most horrendous pain, or they associate periods with something really negative, and I get that. But let's say you've got POI and your periods have stopped and you haven't got major symptoms, so you go along and you function quite well, and you ignore it all and you do nothing, and after 5 years you're told you now have osteoporosis and now you have heart disease and you have a higher risk of dementia because it was left untreated for 5 or 10 years. That is the worst scenario than having been on the contraceptive pill for 10 years, not having known about it, not having had symptoms. And yes, you can deal then with it then. And yes, some of the options you could have had 10 years earlier with regard to treatment and optimizing it, having regular bone scans and checking your heart health, all of these you didn't have. But hey ho, you can't change the past. But now you can be proactive about your health and seek the best possible treatment. And I think that's the difference. But I don't think it makes it's helpful to go back and think, oh, I should have, And it's always important to look at the now and see what you can do now.
I just think it's important for people to be aware of kind of how all the pieces fit together in their health to be able to make the best decision for them for the long run as well. But I think just seeing this flow of how things work with the different things we do to our bodies throughout our lifetime is so important. And like now all these questions in my head for like my own medical history now, I'm just completely fascinated. So another question is, would it be fair to say that the way to treat POI is the same as what you would do for those in menopause? Like is it basically the same? You basically are saying it's the exact same treatments, or what would you say are the nuances? Because in reading your book, I'm reading it, I'm like, oh wow, I feel like I'm reading, all the different things you do for menopause. There were a couple of nuances, but overall it seemed to be very similar. Is that a fair statement?
Yeah,
Okay.
that's correct. I mean, so as I said, ovaries are glands that produce hormones, and if they no longer produce these hormones, we are in a lucky position. And imagine 200 years ago, we didn't have that. 100 years ago, we didn't have that. We now have made pharmaceutically made hormones that are identical to our own hormones. And that's 17-beta estradiol, that's progesterone, testosterone. We can now replace these hormones in the form of a gel, a spray, a patch, a tablet There's so many different ways, implants, if you're lucky enough to live in a country where you have access to this, we would say that replacing these hormones in the form of hormone replacement therapy would be the first line. The reason for that is that you have much more flexibility to find the dose that's right for you. So you have a lot more flexibility with regards to the dose you use of estrogen to get it right, to get into the bone protective range of level that you want. And whereas one of the secondary line treatment options is the pill. The hormones in the pill are better than nothing. Mm-hmm. And for some individuals, they are a good choice, they're the right choice, and it's all about making an informed choice about what's right or wrong for you. A 17-year-old girl may not want to be on HRT. She may actually want to be on the birth control pill, like all of her friends. And you can have this discussion with her, and if she prefers that, you can say, you know what, you will not harm your body by being on this for the next couple of years, but let's have annual reviews, let's check you every year, let's see if that pill controls the symptoms you have and if it's enough. And you can try this is one of the options. If it works for you, you keep going, and if it doesn't work for you, then we can try a different treatment. And this is very much down to the individual's choice, but they need to know, and in order to make an informed decision, they need to know what the best treatment is, and the best treatment would be hormone replacement therapy, because it replaces the same identical hormones that your own body would have made, similar to using insulin. Type 1A or diabetes, if you have type 1 diabetes, you cannot make insulin, you would be dead within hours of not having it. So you just, if you're lucky enough to, you're using insulin now, it is no longer a death penalty. And so I think if you see it like that, you can use appropriate treatments for this. And yes, it is very similar to the hormones that they are the same hormones that we use in naturally menopausal women over the age of 45. But the difference is that the younger person is very much relying on this is for functioning and development and feeling and preventing conditions that might kill you later on and have a harmful effect on your body. Whereas if a 55-year-old woman decides not to start hormone therapy, that doesn't mean she can't be a healthy, happy 80-year-old 30 years down the line, provided her lifestyle is good and her genetics are good. That doesn't mean it at all. Whereas if you leave a 20-year-old individual without estrogen, she probably will have osteoporosis by the time she's 30 or 35, right? So it brings the whole aging process very much forward to a time when it shouldn't be happening. And that's why it is much more important to treat this early, effectively, with the right molecules, with the right hormones, and pay attention that it's not just about symptoms, but also about, you have to tweak it a little bit. You have to do blood tests, which we tend not to do in older women. You just try something and either works or not. You kind of go up and down and fiddle with it. We need to closely monitor these affected individuals who have POI and really get it right. And we don't have much time for complacency. We can't say, oh, let's just not bother for a couple of years and just try again in 3 years' time. You don't have that time. You want to get the estrogen into their system if you can, if they don't have contraindications. Whereas let's say in a 51-year-old woman who stopped the period and she decides not to do anything, but 3 years later she's saying, actually, now I'm ready, I'm having symptoms now, I'm not sleeping, I don't want to be put up with that. She has tried without, and she identified it didn't work for her, so she now has the option of trying something else. The 19-year-old doesn't have that time.
Right.
You want, and that's purely for the prevention of further very serious health consequences if it is left without treatment.
Okay, that makes sense. So I want to get back to HRT in just a minute, but I want to go back to, because you started off by saying you went and got special training for this. So where are we in reality today with doctors being able to properly diagnose these women? Like what should we
Yeah.
Yeah, I'm almost scared of the answer, but I think it's important to talk about because one of the
Yeah.
things with Fempower Health is my mission is to educate women to be able to advocate for
Mhm.
themselves in doctors' offices, and I think it's always important to have that reality check. So what should we be aware of?
So it very much depends on the country you live in, of
Okay.
course. It is. It, we're very privileged here in the UK. Menopause awareness in general has very much increased in the UK. We have a real movement of women, active women educating each other, more and more doctors training. So there's really no excuse here in the UK, at least. I can't speak for any other country, but I know that it's not the same everywhere. That there's no excuse for any doctor not to be aware of this condition. Now, most doctors have a pretty good understanding now of what happens in natural menopause. They don't always take women seriously who are younger. So let's say you're 35, you haven't had a period for 6 months, you're not pregnant, of course, right? So they do a pregnancy test, you have hot flushes, you're not sleeping, you're really anxious, you're very achy. Would every doctor pick up on that? Probably not. You have to be more proactive if you have these problems. They may run a few tests, but they may not immediately think POI, early menopause. At least here in the UK, the healthcare system is very stretched. It is free at the point for users, but they're very stretched. So you have 10 minutes with your doctor. You have to be very much, as a patient, be proactive and bring up this issue. You almost have to tell the doctor, could this be menopause? And even then, there is no guarantee that the doctor will say, oh yeah, you could be right. You have a good point there. Most of the time, you have to push to get the right tests. You have to ask to be referred to a secondary clinician in a hospital, like a gynecologist. You may have to even go private. But so yes, so it is very much still left to the patient to ask and to push and be proactive to get the right treatment. I would think that GPs do not need to diagnose this condition from their end, but in the UK, what they should be doing is they should have the consultation, identify the problem, realize that this is serious, this is not normal, maybe run a few baseline tests, but refer to a specialist from then onwards. It is a very specialist diagnosis because you have to get it right, because it could be PCOS, it could be functional amenorrhea. Yes, it could be stress related. So you have to run the right blood tests to identify, to tell what is what. And no, a GP doesn't have to do these tests, but what their job is to refer to the person who knows how to do these tests. And they do exist. There are enough of us here. But this is where the hurdle is. This is where the obstacles are to really gain access to the person who knows. If your GP puts up a barrier and you have to fight for this, then it takes a lot of your energy. I don't know what it's like in the US, and I would like to hear more about this, but here in the UK, if you're lucky, you have an understanding doctor. It's a little bit of a game. You might be very lucky to have a really good doctor, and most of my colleagues are very well informed, and they may not be able to diagnose it properly, but they will be able to send them off. But there will be some where women have to go not just once, but twice and 3 times over to get where they need to be.
Anything else you wanted to comment there before we go back to the HRT?
Women are not small men. We need to acknowledge that. We need to ask as doctors, we need to be proactive towards our female patients and ask the right questions. And when we go back to saying that periods are a vital sign, similar to having a temperature, so running a fever, or having a fast heart rate, or having pain, so or going to the toilet, being able to I don't know, empty your bladder. So
Yep.
these are vital signs. Someone who hasn't been to the toilet for more than 24 hours is not well. Someone who isn't able to drink water isn't well. So when you have your annual checkup with the doctor, I wonder how often have they asked you, well, how are your periods? Have you got periods? So we need to ask this question as a part of a general checkup. If you're lucky enough to have these checkups, then these need to be essential parts. And we also need to ask women not just, have you got periods, but what are your plans with regards to children. For example, there is a correlation between mums who have an early menopause and daughters having a slightly higher risk of that too. So if I have a patient who's 41, she's in early menopause, she has 2 daughters, I would say tell your daughters that you have early menopause because they have it doesn't mean it will happen, but they have a slightly higher risk compared to a woman who goes through menopause at the natural age. So tell them, make them think about how many children they want. Do they want children at all? If they don't want to, if they're not ready yet and they're 25, they may want to consider having a scan, having a checkup about their egg reserve. Maybe they want to consider egg freezing because they want to leave it another 10 years. But by then, it might be too late. Does that make sense?
Yeah.
So doctors need to ask proactively, need to learn to ask women about their reproductive health, including have you got periods or not. Not just about contraception. Everything's about contraception. No one thinks the other way. You know. So you're so right about that, and we're a long way off, sadly. But I think we're making progress.
Yes, for sure. Absolutely. HRT, like a lot of people are fearful because, back in the day, there was this, I think it was the Women's Health Study and some other things where there was now that they've done further analysis, they're realizing HRT isn't as scary as everyone had thought. And then other things that had also caused these concerns. But it seems like in the UK, there's still controversy with hormone therapy. And I talked to a couple of experts that I know in this space, and one had asked me to ask you this question. So what she wrote is, the pendulum has swung so far to pro-hormone replacement therapy that some experts are starting to push back by pointing out that not all women need hormone therapy. And in the case of POI, most experts agree that hormone therapy should be used at least until normal age of menopause, but there's some debate after that. So can you just talk about what's going on there, and if you had any caveats or words of wisdom to share based on this controversy?
Yeah, it's not, I wouldn't call it a controversy. I think it's just a discussion that happens at the moment. So when we go back to the idea that natural menopause is a natural event. Now I'm not saying that everything that comes from nature is a good thing. Like cancer is a natural thing. Pneumonia is not good. Anyway, but it is an event that happens to every single woman who lives long enough. And the question really is, do we need to medicalize that? So some women see it as a sense of empowerment to go through this rite of passage almost like puberty by themselves. So some women are lucky enough to not have many symptoms that affect their quality of life. And when they speak from their own personal experience, they say, oh, I did this naturally on my own. I just eat healthy food, I exercise, I'm great, I haven't been happier, I'm 57 and I'm in the best place of my life so far. Now, that's great, that's good for her, and I'm so happy for her, but there are women who do suffer quite badly. There are women, the suicide rate, according to the statistics in the UK, is highest between the age of 49 and 54. Women often attempt suicide when they're younger, but they never succeed. Somehow women, there is that last threshold, where they don't quite succeed, even though they're very depressed in a bad place. But when they really achieve, when they succeed to kill themselves, that's in that time, the time between 49 and 54. And you tell me that isn't in some way related to maybe the hormonal transition they go through. So we need to take it seriously, but at the same time we need to find a balanced discussion that we do not make it compulsory for women to go on HRT who do want to do this the natural way without HRT, and maybe just look at lifestyle, nutrition and not drinking alcohol. But at the same time, we need to help those women who require the help. So we shouldn't, whereas in the past, let's say 10 years ago, it was really difficult for women to get a prescription for HRT from the doctor because they were scared by the doctor. They said, oh no, and you can't have it. Look at the risk. The WJ study from 2002 really put doctors off prescribing it, put women off taking it. But we mustn't, now that this view is slightly different, we mustn't leave those women who need HRT for their quality of life and for their general functioning in limbo. We should give them all the information they need to make an informed decision as to whether they take that prescription or whether they go and make lifestyle changes. But those women who decide not to take this shouldn't equally feel bullied into taking it. They shouldn't feel scared into not taking it. So when you say the pendulum has swung the other way, that meant there are some social media posts that you might have come across where it says, oh, osteoporosis happens to 50% of women. If you do not take HRT, you'll get osteoporosis, or you get dementia, or you get heart disease. That's nonsense, right? It's complete and utter nonsense. It's the same fallacy that we told women in the past where we said, if you take HRT, you'll get breast cancer. So there are extremes, and if you read this, you always have to question, what is the agenda of the person writing this? Have they got a huge private clinic that they need to feed, to get more and more women come through the door to prescribe HRT? What is their interest in this whole thing? What is their benefit in putting this scary message out? And that's why, sadly, it has become very confusing, because we have more awareness, we have more specialists on social media who give their bit of advice, each and one of us give our advice, but we need to move away from extreme messages that scare women either way. HRT does not cause breast cancer in every woman who takes it. Equally, if you don't take HRT, you do not inevitably end up with brittle bones, So that's why there are these polarized discussions now. And I've heard women say, you know what, all my friends are on HRT now and I'm not, and all they talk about is, oh, you must go on HRT. They don't even listen to me. They don't say, how are you? And wait for the answer. They think the HRT is the panacea for all evil. It isn't. It is the right treatment for the right person at the right time. But those who decide not to take it should not be fearful of making a mistake or fear of missing out, FOMO, right? So this is where the debate is at the moment. And going back to POI and early menopause, completely different cup of tea. For those women, it is a treatment, an essential treatment to prevent long-term health problems. And yes, they should take it up till the age of 51, because that's when they would be expected to go through a natural menopausal transition where their estrogen levels drop naturally. But if they decide for their quality of life to stay on the treatment they're on because it works for them, then I personally would recommend they stay on, because most women who start HRT are at that age. So why would they need to stop it suddenly when most women now only just started? So the benefits will carry on if they have found a treatment that works for them. But if they do decide to come off them, that's a valid choice too, but we need to give them the information. We need to tell them what are the benefits if you carry on, what are the downsides, and what are the downsides if you don't carry on. And just to be clear, there is no increased breast cancer risk in women under 50 who take HRT. Your body would be expected to make the very same hormones that you replace, and they don't cause you breast cancer either. So do not be scared. If you're under 50, you are on HRT, there's no increased breast cancer risk. The increased breast cancer risk, that is very tiny by the way, is only seen in women over 50 after 5 years of taking HRT, just to be clear. So please do not worry, carry on with whatever treatment you're on if it works for you.
So let's talk about diverse populations and how we see the menopause story and the POI story playing out in that population. Any just summaries that you wanted to provide just to create awareness?
Yes, of course. So equal access to healthcare is not a given at the moment, not in the UK and probably not in most countries. So there are certain groups of women who are currently excluded, or not excluded, but they will have obstacles to access the same quality healthcare that women from the sort of women I see in my private practice, for example. So you have women from different ethnic backgrounds, women who have English as their second language, who have no awareness of menopause at all, who would not be on Instagram reading posts about it. There might be cultural differences where, for example, early menopause, that is obviously very much tied to infertility, where infertility is a major stigma, and where your worth as a woman is defined by your reproductive abilities. So you may got married in certain cultural environments for the purpose of having children, and if that doesn't happen, then your husband may no longer want you because you're no longer useful. So these are cultural differences, and but also in some cultural communities there is it's just not talked about enough. We know that women from black communities often do not talk about it as much, or don't have access to the clinics or to the specialist services. Then we have neurodiverse or hard of hearing women. Often they struggle to access podcasts, for example. We have lots of podcasts, but when you're hard of hearing, how do you access the information, the excellent information you put out there? How do they access it? So and the other thing is also the trans community. Trans men need to know about fertility options. They need to know how the treatment, cross-sex hormones, or puberty blockers, how that affects the fertility and the ovarian function later on as well. So there's lots to discuss, and there are lots of specific groups that we cannot reach easily, and where we need more awareness in easily accessible ways for everyone, so that we can reach all women and all individuals who need the information.
No, I mean, that is such a big entity to solve for as well. I mean, and I like to bring it up as awareness, but it's like, so then what? And I think it's a big conversation to continue having, because we do need to figure that out. But again, I highly recommend that people read your book. And I also just wanted to acknowledge Dr. Hannah Short, who is also a co-author. And I think you mentioned that earlier in the discussion. I did want to just mention this because I'm starting to see it more on LinkedIn as well, around how employers are starting to provide more support to women who are going through menopause or like have period issues and things like that. And you write a really lovely chapter about what employers can be doing. And so just wanted to acknowledge that. And I think for a lot of these women's health conditions, like, we just have different bodies and we need different type of support, and it doesn't make us bad or wrong or anything like that. So just kudos to those who are acknowledging it and making changes to help women still be able to do their jobs, but feel good during them. So what would be your takeaway? What would you have your one statement be that you want people to know or take away from this discussion?
I would say if you are affected or you think you are affected, it can be a very severe diagnosis to deal with. And just remember, you're not alone. Seek help and remember, you're not alone. You don't have to go through this by yourself. Look for the right people to help to support you. Do not do this by yourself. It's difficult. It's hard, but there's always hope. There's always something you can do about it. So yeah, you're not alone.
Thank you. And I did want to actually, since you mentioned that, your book has wonderful quotes from people who are struggling with POI and early menopause. And so I think that'll just give more evidence as people read your book to like hear these quotes and be like, yes, I am heard, because I'm sure a lot of those quotes will sound familiar to people who are struggling. So thank you so much for putting that effort in as well to really paint the picture. But thank you for your dedication. Thank you so much for making time. It's been so lovely to chat with you, and I can't wait to publish this episode.
Thank you, Georgine. It was a pleasure speaking with you.
Thank you for joining me today on Fempower Health. If you'd like to continue the conversation, please follow me on social media. I am most active on Instagram, LinkedIn, as well as TikTok. You can also subscribe to the weekly newsletter if you want to stay off social media to get the latest and greatest updates. And you can find the link to that either on my website, fempower-health.com, which is a hub to all the different health topics I've covered over the past 5 years, or you can go to the show notes where there's links to all the helpful resources that are relevant to this discussion. And if you know of someone in your life who would benefit from this information, please do pass this along, because that is how we can ensure this important information reaches those who need it most. And for anything that is discussed medically, please understand that none of what we share on Fempower Health is medical advice. It is all for information purposes only, and only a conversation between you and your doctor can give you the care that you need. Thank you very much.